adolescent idiopathic scoliosis, and he will talk to us today about the non-fusion surgery for adolescent idiopathic scoliosis. Dr. Beer, please.
Thank you very much. It's a great honor to be here and to speak here. It's my second time this year in Riyadh. I had a chance to operate with Dr. Zamir in July. I have to admit, coming in November is a little bit nicer than in July. So I will talk about the current state of non-fusion surgery for AIS. Some call it vertebral body tethering. Here are a few disclosures. So to know what's happening right now and what will happen in the future, you have to know a little bit about the past. So earlier this century, a few centers, especially one in Philadelphia, tried stapling, and the orthopedic surgeons in this room may know this concept. Stapling was okay. It didn't work that well. It worked for smaller curves, but especially for bigger curves in the thoracic spine. The results were actually not that great. So the concept seemed to be right, but the implant did not seem strong enough. So maybe 10, 15 years ago, then the idea came up, maybe we need a stronger implant that is still flexible. So this is when some surgeons, some of the pioneers started to putting in screws from the side into the lateral body and connected with a flexible tether, which was much stronger. This was a case that I had the chance to join, which was the first case in Shriners Hospital, Philadelphia, 12 years ago. It's a small curve, but 36 degrees, very young, Sanders 3, and her mother of this 12-year-old girl, she had a Milwaukee brace when she was a kid, and she suffered so much. The Milwaukee brace is a brace that goes all the way to the head. And it didn't work, and then she had a Harrington rod, and then it didn't work, and then she had failed back surgery. So she came to a hospital and said, whatever you do, make sure that this curve will not get worse, but make sure that my daughter does not need to wear a brace, and make sure that she will never have a spinal fusion, so which is hard to combine. So this was the first case, and resulted 2 years later in having a straighter spine, which is not fused. After that, the Shriners Hospital in Philadelphia, they collected more data, and they designed a study. And the study, someone has to come up with a design, and design was Linky 1 curves, so thoracic curves. They shouldn't be more than 60 degrees, should be flexible and bent down to less than 30 degrees, and there should be some growth modulation possible. And this worked. So a few years later, the FDA approved the implant, the vertebral body tethering in the US for this curve, Linky 1 thoracic curve, flexible. So now, a few years later, because it was approved 4 years ago, we have studies. We have multiple studies on Linky 1 curves now. This is the current state. We know that approximately 50% correction of coronal corp angle can be achieved. There is a tether breakage rate of approximately 20%, which does not always mean failure, but there's a breakage rate. But what we are debating right now, and you see that on that curve here, on that example, is it really worth it? For a Linky 1 curve, 50 degree, and many of you do scoliosis surgery, and I agree, this could probably have a better outcome with a spinal fusion. You fuse the thoracic spine, they're still flexible, so we are debating different things right now. So we are debating when is the best timing to do this surgery, but what about the lumbar curves? This is really where it's really probably worth discussing it. We have seen a few problems with the lumbar curves, so we're talking about techniques. And as more surgeons, or as more patients having vertebral body tethering, we of course are talking about revision strategies. So what's going to happen for the next years? What is the future of vertebral body tethering? And this is just my personal opinion. So my personal opinion is we have to save the lumbar spine. This is where the flexibility happens, and this is where we really don't want to fuse children. Why do we need surgery for lumbar curves? Because they need treatment. If you don't treat lumbar curves, they will end up being like this, and I'm a pediatric but also I'm an adult spine surgeon, so I see these patients all the time in my practice, and they have severe pain, so we need something. So now you can say we have something, but we don't. You know, fusion is not definitive. This is what we used to say, where we fuse this curve and then everything is fine, but it's not. This is a patient who had anterior surgery, a posterior Harrington rod, pedicle screws, expandable T-lifts, A-lift, PLIF, whatever you can imagine, all in one patient. So we don't have good surgical solutions yet. So I had the chance to start BBT before FDA approval because I'm based in Germany, in Europe, and we have different regulations. And also, I was not forced to do only thoracic curves, so I have collected experience with lumbar curves. And I want to show you a little bit about my learning curve and my journey. I've tethered approximately 250 to 300 lumbar curves, and the technique has changed, and I believe this is where we're also going in the future. So here we have an example, 13-year-old girl with a 64-degree curve, but as you can see, she's very flexible. So it breaks my heart fusing this girl all the way down to the lower lumbar spine because I know she will have problems in the future, maybe 10 years, maybe 15 years, but then she's 30 years old and needs an extension to the pelvis. And I don't like that. So she's still not skeletally mature. Not so much growth potential, but not skeletally mature. So this is a few years ago, and I did vertebral body tethering, and I was quite happy. 17 degrees, not bad. And if she continues to grow, maybe it continues to correct because it's a growth modulating technique. But 1 year later, she actually lost correction, and she probably broke her tether at the lowest level. As you can see, the screw angle, the angle between the screws changed a little bit. So now she's at 30 degrees. 1 year, it's still okay, still acceptable. And at 2 years, she kind of remained stable, although she may have broken another level higher up. So 2 years after surgery, she's probably skeletally mature. She's a more than 50% correction for lumbar curve, but not fused. It's probably somehow acceptable. We don't really get better results with a fusion of the lumbar spine. 4 years later, she continues to lose correction, but it's still below 40 degrees. She has 4 years of flexibility, so it may be acceptable. It's not great, I have to admit. I don't think it's great, but it's probably just okay. So can we do better? So the question is, can we, if one tether works, maybe 2 tethers work better. But before we can do this, we have to ask a few questions. Are 2 tethers maybe more rigid? So we did a biomechanical study. We went to the lab and tested in cadaver spines, 1 tether, 2 tethers, and all the way on the right you see some kind of an apical treatment with an apical fusion and tether. It's a hybrid. And what we found out is that especially for rotation and flex and extension, there's still, even with 2 tethers, there's still a lot of flexibility. So it's not rigid. It's still a motion-preserving technique. And then we started clinically. Here we have a young girl, 15 years old, almost skeletally mature, 41 degree, severe coronal imbalance. So we could discuss if we fuse her to L2, 3, or L4, but she's so flexible, as you can see here. So I did a 2 tether technique for her, and I intentionally overcorrected her because even with 2 tethers, I believe the tether will break. And at 2 years now, she's skeletally mature. Her coronal balance completely improved, but she lost correction. She's at 9 degrees now. I think it's a great outcome, 9 degrees, but even though she broke her tether. If you look at the middle of this construct, I don't see the pointer here, but if you look at the apex, the screws opened up a little bit, so that means she probably broke her tether there. But again, skeletally mature, 9-degree curve, coronally totally balanced. But not everyone is like this. Here is our data on 2-year outcome after 2 tether technique for lumbar curves. So in average, we get a 50% correction, but 90% of patients actually still break their tethers. I think it's important to understand that tether breakage does not mean failure. So even if you break your tether, you're at 20, 30 degrees, 50% correction compared to pre-surgery. But I think we should even get better. So this is where we're going the next few years. Here's an example of someone who failed. 72-degree curve. A severe rotation. If you look at the apex, we almost have a lateral X-ray. She's 16 years old, but look at this flexibility. It's hard to fuse this kid. She has 6 lumbar vertebrae, so we're discussing fusing down to L4, maybe even L5. She's almost skeletally mature. So I did a 2-tether technique, 2-cord technique, and the initial result is not that bad. But as you know, even with the 2 tethers, they can break the tether, and this girl also lost correction. 1 year after surgery, she's at 31 degrees, which is still acceptable compared to before surgery. But at 2 years after surgery, I would say it's not really acceptable anymore. This is a failure. So what can we do now? You can always still fuse it. So if you look at the X-ray all the way on the left, she would require posterior spinal fusion probably, maybe anterior, but many would do posterior. If you look at the right, she still requires a fusion. So we decided not to do a fusion, a full fusion, and I checked the tether. So this is what I found intraoperatively. The bottom at L3 and L4 broke, both tethers, and the posterior tether at L2, 3 broke or was about to break. The anterior was intact, but look at the rest, L2 and higher. Everything is completely intact after 2 years, not even single scratch. So I believe that her bad disc are the disc L2, 3 and L3, 4. So now how can I do a 12-level fusion for a kid if I only have 2 bad discs? So then what we did is I exchanged the tether and I fused L2 to L4, as you can see here. I just put cages there. So now she has a 2-level fusion coming from a 72-degree curve to 0 degrees. She's not 100% flexible, but she only has 2 fused discs. So I believe this could be something in the future, and it changed my mind actually. It changed also my technique. If you look at this 14-year-old girl with a 45-degree curve, I know that even 2-tether technique probably doesn't work. If you look at the apex, it's a rigid apex in the bending X-rays. So now from the beginning, I fuse the apex, because even if the tether breaks, then this apex will stay intact, will stay stable, will not lose so much correction. And I believe this could be one part of the future treatment that we may have to sacrifice 1 or 2 discs. So the double curves are the real challenges. We have so many different options. And I want to show you an example. This is a 15-year-old girl. In my older days, I would do T4 to L4 fusion, maybe T4 to L3 fusion. This is the standard, I would say, double curve. But saving the lumbar spine is the goal for the future. And even though there is probably a risk for failure, so I did a selective fusion. She's completely off-balanced now, but doing more deselective fusion for double curves also shows me that it's actually not that bad as it's supposed to be. So this one worked out with a selective thoracic fusion, and I was able to save the lumbar spine 2 years after surgery with a curve below 30 degrees. How about this one? This is more difficult because the lumbar curve is bigger, so it's a Lenke 6. And if you look at the bending X-rays, the thoracic curve bends, it's flexible, bends to 23 degrees. But the lumbar curve only bends to 41 degrees, which is not really flexible. If you look at the apex, L1, 2, this is the main reason why it's not flexible. The apex, 24 degrees of these 41 degrees are only located in the apex, even though she's only 11 years old, so growth potential is not the only reason. So what did I do? I did a double VBT and I fused the apex, because the apex was the stiff disc, and so I eliminated the stiff disc, and then you have much better outcome. So how about this one? This is a flexible, the thoracic is not that flexible, but the lumbar is very flexible. CNS3, very young, pre-knuckle. I thought I could do a double tether. I believe even the thoracic spine, I can get a little bit with surgical techniques, I can get a better result in surgery. But I usually get an X-ray on the day before surgery. She comes in 3 months later, and her scoliosis looks like this. So it's just these kids, they progress so fast. So now I'm not able to do a double tether anymore for the thoracic curve. So even here we have new technologies and techniques to fix this curve. And again, saving the lumbar spine should be the goal. This is what I did, a thoracic fusion and a tether in the lumbar spine. So I had to sacrifice the rigid curve, but I think it's fair enough to save the lumbar spine. With this, I want to conclude my talk. What are the future perspectives? I don't have the answer, but in my personal opinion, I believe we can probably do less VBT for thoracic curves. We do more now, but sacrificing thoracic flexibility is probably okay, but we need something better for thoracolumbar and lumbar curves. I believe that we don't only look at curve magnitudes in the future, but we really go on based on segmental parameters. So we look at each disc separately, we look at maturity status, age, and all these other things, and maybe in the future, artificial intelligence can help us defining our treatment. Thank you very much for your attention.
Thank you very much, Dr. Trobisch.